Welcome to the ACO Show, a podcast about the American healthcare system and some of the people who are trying to make it better. I'm Josh Israel, joined by my co-host Sean Cavanaugh. And today our guest was Catherine Olexa-Meadors. She is a former close colleague of me and Sean, and she is now the head of growth and partnerships at Town Hall Ventures. And we were talking about the ACCESS program. So Sean, can you try to give us a quick explanation to set everybody up for what's coming for this interview?
Yeah, I'll take a stab at it and then let Catherine give what a bit more business-oriented investor perspective is. And I'm going to keep a close eye on you because I can always tell if I've been clear or not, or if I've lost you. It'll guide me in my description. So CMS just announced a new model. It's going to be called ACCESS, and forget what the acronym stands for, but all their new models, the names are actually acronyms. But the way to think of this is they are creating a payment system for services that are not typically covered by Medicare to help Medicare patients manage their chronic diseases, hypertension, diabetes, cardiovascular disease, depression, anxiety, and musculoskeletal pain. So things that are very prevalent in a Medicare community and that people suffer greatly from and could use better management of. And saying, we know paying doctors and hospitals to treat these gets us some results, but we think there's new ways of doing this that a Medicare fee schedule doesn't properly recognize. 2/3 of Medicare beneficiaries have these conditions. Some of them are getting managed by their doctors, but there's a whole industry of new companies. Some of them are technology-based, some others promising that they can help directly work with these beneficiaries and help them better manage it. And the important thing is the things they do, Medicare doesn't currently pay for. So it could be counseling, education, those sorts of things, lifestyle management, exercise, which can be all good for you, but they're not covered benefits in Medicare. So CMS is trying to create a controlled environment to test, is there a way we could pay for this that will actually lead to better outcomes? And so they're developing a new payment system that literally will be tied to outcomes. So if you sign up, if you, Josh, started a company and said, I'm going to control hypertension among Medicare beneficiaries, you would have to report the actual blood pressure readings from your patients. And as they improve, you would get payments based on that improvement. There's a million bells and whistles and contingencies. And then CMS is going to evaluate the model. And they're going to have a control group of people who want these services, but will be put in a control group and not receive them. So they'll see how their health changes compared to the involved population, how their costs change. So in some respects, this is an area that CMS has been working on since the 80s, chronic disease management. In some respects, this is very new because technology is very new, and this is a very different form of payment than they've tried before.
All right. And, we had Abe Sutton, who runs the Innovation Center at Medicare, on the show, and Farzad was teasing him a little bit that everybody who takes the role tries to come up with a new model, and did we really need a new model? When you heard the details of this model, did you think, oh, good, I see the role for this?
Yes. We get into this in a little bit in the conversation with Catherine. I think they're a fundamentally different environment now than when CMS has tried many of these in the past. And the short version is the intervention in the past was a telephone call. Lots of disease management companies would have a nurse call you and try to coach you. Technology's changed on how to target these patients and how to engage them. I do think it's worth testing those in a very careful way.
Well, now that we've framed it up very well, thank you for that. And let's dive into the details. I think that it will help our listeners understand it. It did help me understand it, this new program.
Welcome, Catherine. Glad to have you here today.
Thanks, Sean. It's great to be here.
In the intro, we mentioned that you formerly worked at Aledade, and we know you well, and you're a friend and colleague, but that you currently work at Town Hall Ventures. Can you explain to the listeners what Town Hall Ventures is exactly and what you do there?
Absolutely. I'm pleased to see you and Josh. When I was talking to my little sister today about doing this podcast with you, I told her that I had to leave Aledade to get my second invitation to join the pod. But yeah, glad to be here. Like you said, 7 years I spent with Aledade with you all, building out lots of great things on clinical innovation and our care model at Aledade. And when I got the chance to think about what I could do next, one thing that was really compelling to me was the way Town Hall had designed their and developed their mission around increasing access to health and healthcare for underserved populations. And I know that that's maybe saying the mission of Aledade in a slightly different way, right? Like I think we always at Aledade wanted to reach these same populations through making sure they had access to primary care. So it really resonated with me, the core mission of Town Hall and what they're setting out to do. And as you may or may not know, we were started, one of our two co-founders was Andy Slavitt, who is, you're part of the CMS family, Sean. He was the former acting administrator. One thing that really closed the deal for me was when I talked to him about why he started Town Hall. And he said, what I realized when I was in the administration was that a big part of the high cost of healthcare in our country was actually the fact that folks weren't getting the healthcare that they need. And so all of a sudden, when they have an emergency or like an acute event, they go get really expensive healthcare. And so how could we both influence the policy side to promote, more equitable, more accessible, more achievable health and healthcare that's not high cost for folks, while simultaneously investing capital in building those companies. And so Andy and the team here have done a fantastic job over the last, they started in 2018, of building a group of investors that invested in their fund that are some of the biggest strategics in the game, right? We have health systems and payers, and they represent all sorts of populations around our country, all sorts of geographies around our country. It's not just Medicaid, it's all payers, all people in our country. And I feel like there's a really compelling group there that are motivated to, yes, see a return on their capital, but also make a difference and improve their populations. And, I was speaking to someone who I won't name from a different healthcare specialist fund recently. And she said, the reason why this is so compelling for strategics is, you wouldn't invest in healthcare innovation if your only motivation was return on capital. You would go invest in, other things that give you much higher margin. She said, but if you have a core business that has to survive, right, and navigate this situation, you might invest in venture capital that's focused on healthcare. So that's what we do at Town Hall Ventures.
So Catherine, I think you are the first Aledade alumni that we've had on the show. I think we can assume that means you left here on good terms. It's good to see you back.
Certainly good terms with the two of us.
This show, we're going to focus on a new model that CMS has just released information on, the ACCESS Model. What's the fundamental problem that they were trying to solve with that, as far as you understand it?
Yeah, I had the chance to join. I geolocated close to DC. So Andy sent me to the meeting at HHS where they sort of announced this. And it was actually a great meeting. They brought together HHS and the FDA folks and the CMS folks, and they really made a big deal out of it. And I think there's a reason for that, Josh and Sean. And from my perspective, it's because there really just historically hasn't been a way to pay for technology first, or primarily technology innovations on the clinical side. And so lots of us who have been working in healthcare innovation, and I'll speak for myself, even prior to Aledade, I really believed that the value-based care wave was the way, you were going to get these innovative solutions to patients and get them in their hands. And I think we did do that and have done that and continue to do that through the models that exist. But where it was, frankly, a real, you guys will remember this, I literally tried to do lots of this at Aledade, where it was, let's find a partner, a solution that could help us with the blood pressure control, the diabetes control, the weight control in between primary care visits. And what we were often confronted with, and Sean, how many conversations did we have about this, was just the payment for those things really was the options were thin, right? They could either become a provider group and figure out how to bill for CCM, chronic care management, or figure out how to bill for remote patient monitoring. But even if they did go through all the, hurdles and obstacles that exist to become that group and to do that billing, the ROI for them to do the billing was just so low, right? So I think what's really fundamentally interesting here is you start to create a category and an opportunity for these groups that have really awesome digital engagement models and things that really do work and have evidence around them. And you start to provide a way to pay for those that never existed before. The other piece that I wanted to mention just on that point is, and I think you'll agree with me here, like the real thing that I'm excited about with this model, I'm not saying that they'll have figured out all the mechanics here, because I think there's devil's in the details, but this concept, and we can get into this, of paying for an outcome actually hasn't really been tried before. So we'll get into that, but I think that's one of the most exciting things they're solving for.
We will get into that. But first, I want to go to where you went first. So you mentioned technologies. And if you read the request for applications, which CMS issued, there aren't a lot of requirements that these be technology-based, but you can read between the lines and tell that they're thinking about technology solutions. So as you mentioned, I worked under Andy Slavitt at CMS, and CMS has run decades, literally decades of disease management demonstrations, even far predating the Innovation Center. And they all were largely unsuccessful in both improving care and reducing costs. And there were a couple, and when I read this, I was like, why would this be any different? And technology was one of the things I first went to. Like, there were whole generations of technology that didn't exist. The technology that was used in most of the previous demonstrations was telephonic disease management. So the technology was literally a landline phone calling you, did you take your meds? Did you take your blood pressure? So I think it's exciting that we're going to get a whole range of technologies tested. But there are some other things that have changed too since then. I mean, one of the technologies is AI-driven analytics. So Catherine, one of the things when you were working on all these things at Aledade was, who are the patients who could most benefit?
Yeah.
Who are the ones most at risk, not just of developing this disease, but ending up hospitalized? The science, the data science of targeting people has gotten so much better since 20 years ago when CMS was testing this. And then you mentioned another thing and we should dive into this, which is payment. In the old demos, the disease management vendors were paid for engagement, which meant if you could get a patient to sign up, you got a payment. And so you weren't trying to find the most impactable patient. You were trying to find the most ready to sign up patient, and you weren't focused on outcomes as much. Here, and as you said, we'll talk about it. The last thing, and we will talk about this as well, is all of those demos struggled to engage primary care docs. So you had a third-party vendor trying to help you manage your diabetes, trying to help you manage your hypertension, with little or no clinical connection to the patient's actual primary care provider. So I apologize. I do this all the time, is dive deep into the history of CMS, but I think it's relevant here.
Yeah.
Why are we doing this? Because lots of things have changed since the last time we tried to do this.
Absolutely. And I think you're right to say that, Sean. And how many times in our careers have we talked to people where they'll say, oh, this quote unquote innovation is not an innovation. I've seen this movie 10 times before, and like, what's going to play out differently? And, I think that, to your point, just this intersection of a test that CMS wants to run with the literal advances in technological capabilities, and those two things colliding is where I think there's some new white space here that really didn't exist previously. So when we think about how big this thing could get, and if you're a primary care doctor, like, and Josh, we're talking to you sitting here as the doctor in our midst, right? Like, 2/3 of your panel, at least in terms of Medicare, could be eligible for this, right? So this is not some little drop in the bucket. It's not like a 2-year program. It's a 10-year program, right? So I think there's something to pay attention to here if you're a line physician, or even if you're a hospital executive, or whoever you are out there in the health ecosystem. This is probably something worth paying attention to. And the way we're thinking about it at Town Hall really is in a couple of different ways, Sean. And I have to give Andy Slavitt credit here. because, he's been working really closely with the administration and with Dr. Oz in particular. And you might know that he's been running the CMS Learning in Action Network and, really sees himself as a guide for a lot of the folks who've come into some of the leadership roles at CMS right now. And, he, with others, seeded this type of concept well over a year ago and said, hey, we want to invest on the private side in these types of things. They have to have a way to get paid. They have to have a way to get to patients. And we have to have incentives for these companies to build models that could reach a broader population. It's really hard to engage patients, even when you have a primary care doctor, kind of either directly or indirectly making the referral. So the engagement itself is difficult. And retaining the engagement of the patient who does engage, that person you mentioned that's ready to sign up, is even harder than engaging patients. And so when you think about the solutions that exist today, a lot of times what they're doing by necessity is trying to find the most impactable patients who they can reach sort of in the lowest cost way and then apply what amounts to like a pretty expensive care model to that really small group of patients. Where I think this opens a different kind of door for our portfolio companies and for maybe new companies that get built is to think about in a much more like Silicon Valley kind of product development way. How do I build something that patients actually want to do? How do I build something that will keep them engaged? How do I use sort of the Facebook mindset of like, I actually want them to engage in this and have fun doing it and want to keep coming back to it. I think we've in healthcare treated a lot of this in between care as like, we're doing it to the patient and we're doing it for the patient, but we're not doing it in a way that they really perceive a ton of value. So to me, this is maybe one of the most interesting things this model will do because of the way it's going to be paid for, where you kind of get half of it up front and then you just can't get the rest if you don't keep the person engaged. They're going to almost have to figure out this gamification piece or whatever you want to call it to keep people coming back and actually achieve the outcome you're looking for. So hopefully that wasn't too deep, but I think that's one of the most interesting things about this.
Sean, how do you see accountable care organizations interacting with a model like this?
Yeah, so as I see a couple potential approaches by ACOs. One is ACOs may want to develop interventions, technology-based interventions themselves to provide services to their member doctors and hospitals that would then be reimbursable under this model. I have to be honest, I don't think that's, if you read the CMS documents, I don't think they anticipated that, but it's certainly allowable. So do we want to become what in this context would be called an access provider? Do we have technologies and interventions we want to provide? I think something more aligned with CMS's vision is, do we want to advise our doctors on, hey, there's 10 of these things out there. Here's the 3 we think really work and that we should engage with, and then facilitate that engagement. We could be the ones helping our practices find the most impactable patients. We do this already for Aledade type interventions. The reason why I think that's consistent with what CMS is looking at is one of the reasons Catherine mentioned is these access companies need someone to refer them patients. They could go direct to consumer, but they don't know which Medicare patients have diabetes. And so they could spend a lot of money just trying to find people and trying to get engaged. But also, and this is what I think is really critical, is it's not enough to get the referral, because I do think, as I said, the lesson from the old disease management models was if you do this and you're not integrated with the primary care provider and other things going on with the patient, higher chance of failure. So getting a referral from a PCP, but not just the referral, but maintaining a relationship, I think will be critical. But this is a couple days old that we're familiar with the model. I'm sure everybody will have even more interesting ideas as we dig deeper into it.
Yeah, and we should talk about, even though it would be a little bit fuzzy math on our part, like who's going to be motivated to go build in this space, right, Sean? Because I think everyone's waiting for that price tag, right? And even in the RFA from this week, it was like, you should apply, but also we're not going to tell you how much you could get paid, which in a way is like a lot of job applications or job postings historically. Now some states require you to post the salary. But, it's a little bit funny to me to say, come apply for this thing. It's a mystery how much money you could make if you got it, So,
Yeah. What are your preliminary thoughts on how and to whom one would invest in this?
yeah, well, so I don't want to speak for our deal team, and I won't proclaim myself to be an investor, but I do think that um, it would be unlikely, in my personal opinion, for a company to be built with access as the thesis for the company, right? And I think one lens you would have to ask yourself as a CEO is like, could my business exist if access didn't exist? Because as you all know, there's lots of risks with models like this. And sure, you could have a 10-year model, but the staff at CMS changes over, at the end of the administration, or it proves that it's like, to your point, Sean, like running up a huge bill and CMS can't afford it. Like there could be different things that happen down the road. So I think you don't build your company around a model like this, and it's not necessarily like the most sustainable thing long term. So I would say that as number one. Like, do you have a business model outside of access? If yes, collect $200 and go. In terms of product lines, I think that's where it gets really interesting. Right. So when I think about it, I would probably think less like fully new companies that are going to come out, and a lot of companies and frankly provider groups that will try to participate or try to add a product line.
Catherine, you mentioned a couple of things, specific things about the model, and I should spend another minute or two explaining the model. These are tests of ideas that CMS runs pursuant to its authority. Historically, they've been running 3 to 5 year tests. This one has been announced as a 10-year test. Applications are due to start in 2026, are due in the spring, but they also indicate they'll have a rolling admission so that, we anticipate people will apply in subsequent years. And that's why the 10-year timeframe is important. You also mentioned payments. So I want to clarify, there's 2 types of payments under this model. The first are what are called OAPs, outcome aligned payments. And that's to the participant who comes in and says, I'm going to control hypertension for the patients that I can sign up. And they receive a per member per month payment, but much of it is contingent on demonstrating actual improvement in hypertension, or for patients who get to control, actual maintenance of control. So CMS will be doing these calculations on a patient-by-patient basis and calibrating the payment to the participant based on that. Catherine, you accurately mentioned how much those payments will be has not been made public yet, as you can imagine, both from an ACO perspective, but also from a business perspective. That's a big deal, and people are eagerly awaiting that information from CMS. The other payment that's not gotten as much attention is called a co-management payment. And this is a primary care physician primarily, but others as well, who refer patients to the access participant, or are just managing these patients while they're in these models, can receive up to $100 a year for monitoring the data of what's going on as the patient participates in the model. It's not a lot of money. There's a lot of people questioning whether it's sufficient to get the engagement of the PCP. But what I like is that part does speak to a weakness of prior models, which is that the PCP was entirely cut out. It may take more work, it may take more money, but at least they've put a flag in there that they know that's an important component of it. So Josh, as the representative of the physician community whose head is spinning, does that help you get a better sense of this, or do you need more?
I think I'm probably going to still need some more, but I would be interested in it. And if you're people who are doing value-based care work, we all know with this very long time frame of doing the work and trying to get paid for better outcomes. And so if this is something that aligns with that, I'd certainly be interested.
The other thing interesting thing that doesn't happen in a lot of CMI models, some patients who sign up and say, yes, I want to be in, will actually be randomized to a control group and not receive the intervention.
Yeah, that was an interesting.
Yeah, and that's hard to do, and that's why it's not often done. But this will allow CMMI to say, are your patients actually getting better faster than they would if they weren't in the intervention? And also ultimately what's happening to total cost of care for the two populations. So that's a component of it that I think is very intriguing.
Catherine, anything else on your mind as we talk about this, as we near wrapping up?
Yeah, the only thing I was going to say is maybe to turn it around with you guys a little bit and curious to your pros and cons list as you're thinking about it. What are you optimistic and pessimistic about?
One of the things we've learned in the slightly over a decade of the Innovation Center is the models that seem to work best have someone somewhere responsible for the total cost of care. And this has been variations on ACOs, but even some disease-specific type models. A little bit of concern here that there might be patients who get into this model that are not in ACOs or not in anything where anybody is keeping an eye on total cost of care. So that's a concern. The upside is there are 11, 12 million Medicare beneficiaries who are eligible for this model who are in some form of ACO, and this model might hold out some hope of solving that problem.
Well, Catherine, Olexa-Meadors, formerly validated, now head of growth and partnerships at Town Hall Ventures. Thank you for joining us. We're recording this actually on a Friday night, so hopefully we were as fun as a happy hour.
Hey, it was great for anyone who's a policy nerd. So we really appreciate the time, and thanks for including me. Good to see you guys.
Good to see you.
Bye-bye.